Thank you. I would be talking to you about DSEC, the pre-cut tissue and Indian scenario, pros and cons. And I think this is very much required in a country like ours, where there are constraints, especially from the economics point of view, and not all centers and all places can have automated microkeratomes. So if the pre-cut tissue is available, it is always added advantage. Now, the donor tissue preparation generally can be done in two manners. One is the surgeon himself can cut it in the operation theatre, or an eye bank technician can do it in the eye bank, and alternatively, from a center where a microkeratome is there, you can request for the tissue to be cut, and it can be transported back to your center or to your hospital. These two methods of cutting, that is for posterior lamellar keratoplasty, that is manual, and automated microkeratome, have already been discussed. And what we are looking at is the posterior lamellar lenticule, which is 150 microns, or nowadays more fashionable is to have 100 microns for posterior lamellar keratoplasty. What are the benefits of the pre-cut tissue? The benefits of the pre-cut tissue are that the surgical time is very much reduced. It reduces the intraoperative complications related to the donor preparation because your donor is already prepared. It is a viable option for endothelial keratoplasty for developing countries due to non-availability of the microkeratome related to the cost factor. You can also do specular microscopy and slit lamp biomicroscopy prior to the surgery and after the tissue dissection to evaluate the endothelial status, which is not feasible inside an operating room. And availability of the pre-cut tissue makes the procedure widely accessible. An absolute requirement for this would be a well-equipped eye bank with a trained personnel, or alternatively a surgeon can do it in the operation theatre. Meticulous tissue grading, tissue dissection, pre and post dissection endothelial assessment, proper storage, and very important, proper transport facility. Now, this is how the pre-cut tissue looks on a slit lamp evaluation. You can see the lenticule which has been placed again, and you can actually see it on the slit lamp and you know what is the thickness of the posterior lamellar lenticule. It is very important to know where your tissue is stored. For instance, MK media, which is most commonly used in our country, because MK media stored corneas are a little thicker, as opposed to Optisol stored corneas, which tend to be little thinner. And organ culture, of course, is not used here, but is common in Europe. Now, for a pre-cut tissue, this is the Moria microkeratome system which is being used. The corneoscleral rim is placed on the artificial anterior chamber, and this is followed by the placement of the cap that comes with it, and followed by the placement of the suction ring. It is important to see that the edges where the microkeratome will cause the excursion are not dry, because otherwise it will drag the tissue. You have to guide the speed of the microkeratome yourself. So if a surgeon requests for a thin tissue, then you make the speed slower, say something like 20-22 seconds, and if it is for a thicker tissue, then you make the speed a little faster. So you can control actually the thickness of the lenticule. Also, the key figure to remember is 570 microns. So if you are using, if your pachymetry is more than 570 microns, then you use a microkeratome head of 350 microns. And if it use a microkeratome head of 400 microns, and if it is less than that, you use 350 microns. It will also depend on the surgeon experience. For instance, if it is a novice surgeon, he may want a little thicker tissue which is more easy to handle, as opposed to an experienced surgeon who may want an ultra thin tissue to handle because he can do it. After cutting the anterior lamellar lenticule, it is important to actually see that the edges of your cut are actually dry, because you have to give these marks, and this is the toric marking pen which is being used at the edge of the keratectomy for the surgeon to actually see where your keratectomy is. And also it is always better to give a central mark so that he can align the center with the center of the Teflon block where he is going to place the tissue. Having done this, the pachymetry is done again. to assess the thickness of the posterior lamellar lenticule, and very carefully the anterior lamellar lenticule is also pasted on it, much the same way as you would do in LASIK, taking every care that the edges of this overlap or apposition are dry. And these become by the capillary action of the Mirosol sponge, and after you have done it, you flip the microkeratome assembly, you invert it completely, and then this anterior posterior lenticule complex is slid. It is not flipped, but it is slid over the over the artificial chamber, and this is then placed inside the media. This is the Life 4C bottle. Alternatively, you can also do it in cases of MK media as well. But the only thing is it gives very good support, and the tissue doesn't move if you do it in these Life 4C bottles. And then you place the media on the from the edges onto the conio-scleral donor rim and the posterior lenticule, and this is how the surgeon then retrieves it, and he knows where to punch exactly, because all your edges as well as the center is marked. We have been giving eyes to Guru Nanak Eye Center, and we've given 35 such eyes. From the GNEC Eye Bank, whenever we get a call in the RP Center OT, we cut the eyes, and then the same day the eyes are transported back to the GNEC operation theatre. In fact, the man keeps sitting there just in front of the OT to collect the eyes back. Now, there are issues with the pre-cut tissue, the impact of the storage time on the pre-cut tissue, the tissue thickness, endothelial cell survival, visual and refractive outcomes, graft dislocation rates, and microbial contamination. In the initial studies, it was shown, and the sample size was very small, that there is swelling in the anterior lamella, but not in the posterior lamella, but not in the anterior lamella, and there is some endothelial cell loss as well, but it did not make too much of clinical significance. And in one study of 22 eyes, there was 18% donor non-attachment, but probably that could be related to other surgical factors as well. However, the later studies have shown, with a larger sample size of 100 plus eyes, with the tissue stored in the Optisol media, that the results were quite good. The endothelial cell loss was only 3.7%. And another study by Terry et al. Showed endothelial cell loss at 6 and 12 months to be 31 and 29%, which is very much comparable to the surgeon cut tissue. And this is the prospective study which was done to compare the pre-cut donor as compared to the donors which were cut on site by the surgeon, and again the endothelial cell loss was acceptable. In fact, similar in both the groups, and the dislocation rates were also similar. There is a study by Ide et al. To see whether whenever you have the anterior cap on the corneoscleral rim, whether it makes a difference or not, versus those cases where it is off. And in one study it was found that endothelial cell damage, when the caps were off, then the damage was more. Whereas in the other study in which the corneas were stored in the organ culture media, it was found that there was no difference whether the cap was on or off. But we do believe from personal experience, because we transport the tissue in the Optisol as well as in the MK media, that it is always better to keep the anterior lamellar button on, because that causes less imbibition of fluid from the keratectomy edges. There is influence of pre-cutting, and people have even transported these eyes overseas, and overseas transportation before and after the pre-cutting did see that there is a decrease in the endothelial cell loss. Rate of endothelial cell loss was 1.7% for pre-cutting, 3.79% for overseas transportation, with a total of 5.6%. But all the endothelial cell counts in all the tissues had counts more than 2,000 cells, and all grafts were available for dissect. And this is a study which compared the microbial contamination rates in the pre-cut tissue to see if there was more infection with this, and this study did not find any difference between the pre-cut and the surgeon cut tissues. Again, organ cultured pre-cut tissue versus surgeon cut corneas did not find any difference in the endothelial cell loss or in the central corneal thickness between the two types of tissues. And this is the latest study which has shown DSEC with internationally shipped tissue. The tissues were shipped to Japan from Seattle, and these were Optisol preserved eyes, and mean post pre-cut endothelial cell loss during international shipment was to 2.3%, which was acceptable, and the mean elapsed time from the cut to the surgery was 63 hours. And outcomes of DSEC were found to be acceptable, and additional endothelial cell loss associated with international shipment was minimal and did not affect the clinical results. Complications are there because of the pre-cut tissue, which include tissue wastage because of the wrong cut due to faulty technique. Then pre-cut tissue may be slightly thicker as compared to intraoperative dissected tissue, and there may be anterior lamellar tissue dislodgement in the storage media. And we need to solve certain issues such as the safe duration in which the tissue can be harvested and transported. And studies are required to compare the cell loss vis-a-vis specular microscopy and vital dye staining, and additional iBank instrument and personnel costs have to be worked out. So to conclude, iBank pre-cut donor tissue is comparable to surgeon dissected tissues in terms of endothelial cell loss, dislocation rate, visual and refractive results, but we do need long-term data to again confirm this. And DSEC pre-cut manual preparation may be also cost effective, and more iBank technicians need to be trained on it, and the cost constraints of microkeratoma automated technique make it a viable option at select institutes and centers. Thank you for your attention.